12 minutes after 8 o'clock, 92.1 WROI. WROIFM.com, 61 degrees and sunshine outside the window on 8th Street. We are streaming audio live on RTC Channel 5 and audio, soon to be video, on RTC Channel 5. That's why Scott is in the studio with his coffee cup again this morning. Hey, Scott, how you doing?
Good morning, Tom.
Hey, nice to have you back with us.
Good to be here.
Time for our second edition of the month of a program called Doc Talk. We have started that this month from the folks at Woodlawn Hospital, and we invite your questions, your comments. You can call us with questions at 223-6059, WROI at rtcol.com, or, as a lot of folks like to do anymore, social media. You can post those questions on our Facebook page, and feel free to do that. Well, each fourth Monday of the month, we're going to be talking with Dr. Eric Seward, who is OB-GYN at Woodlawn Hospital. Dr. Seward, good morning.
Good morning.
Thank you for being here.
Thank you.
You've done this before.
I have.
At other radio stations.
I have.
In other places.
In other places.
Throughout the United States of America. Right?
In fact, the last time I was on the radio was in New Mexico.
Really?
That's right.
Okay. A show similar to this?
It was, yes. Okay. It was a weekly program that aired.
All right. And so did you get a lot of listener involvement through the course of that program?
We got some.
Okay.
We got some.
Okay. All right. Anyway, nice to have you with us.
Thank you.
You're new in the community. Tell us a little bit about Dr. Eric Seward, would you please?
Yes, I will. I practice OB-GYN. I am a native Indiana product, a Hoosier at heart. I grew up in Muncie. Have spent approximately 7 to 8 years practicing between Muncie, Marion, and Hartford City. I did my initial schoolwork at Ball State, went to Indiana University School of Medicine, did a Michigan State residency, and then worked for a while in Wisconsin, spent the bulk of my career in the great state of Indiana. The last 2 years I was in Santa Fe, New Mexico.
How is it different to be in Santa Fe, New Mexico than to be in Indiana?
There is not as much rain. And there are a lot more mountains.
I bet that's true. Nice warm climate?
Not too warm.
Okay.
I think it's where we are, it's about 7,000 feet. So it's a very temperate place, but dry.
How did you end up at Woodlawn Hospital?
Well, the opportunity arose.
Okay.
They were looking for somebody first to cover for a couple of months and then hopefully to stay on permanently, which happens to be me.
And your family is looking forward to getting back to Indiana?
We are,
okay.
Collectively.
All right, very good. You're here now, so we're going to be talking about, let's talk about OB-GYN, the specialty itself. Yeah,
we are basically, to start out with, OB-GYN is one of the many specialties that you can get to through residency programs. In our community, we've got family practice, internal medicine, general surgery, orthopedics, a number of subspecialties. In my case, it's OB-GYN. The OB part of that is obstetrics, meaning dealing with the delivery of babies and pregnant moms and all aspects thereof. The GYN part is gynecology, which is dealing with all issues female-related. We basically start up at puberty, and we deal with just about everything that comes up.
Okay.
Within the whole female half of the spectrum. In particular, with the obstetrics part, that tends to be something that I focus a lot of. Probably about 50% of my practice is dealing with everything that goes into delivering babies.
Okay.
The other half, ironically, we spend a lot of time dealing with not having babies. We do a lot of birth control, and we do a lot of general wellness. We do a lot of, in my case, I do a lot of pelvic prolapse and urogynecology, incontinence procedures, things like that. We deal with a lot of menstrual issues, menopause, hormone replacement. And, we try to address all health needs. We do a lot of the mammogram screening, ordering, a lot of pap smear screening, and just about anything that might have to do with general health screening and wellness.
Interesting to note that you're here today, but starting in October, Breast Cancer Awareness Month comes back.
It does, and we try to keep a focus on that. That's one of the probably the biggest issues and one of the biggest fears that sort of run through, particularly our 40 and 50 and 60-year-old crowds, although on either end of that. And we do a lot of breast cancer screening through Woodlawn Hospital and through the primary care practice.
And men are not exempt from breast cancer.
Not exempt. In fact, there's one of the genetic mutations, BRCA2, that is exclusively or very, very closely linked to male breast cancer.
Right. Okay. I heard you use a term here a while ago, or as you were describing this, that seems to be finding more and more popularity, and that's the term wellness. Important to try to keep people well.
Yeah, of interest, and I think this gets back to OBGYN is a very unique field in the sense that we cross over between primary care and specialty. We think of our general surgeons and orthopedic doctors as being specialists, our family practice and internal medicine doctors, pediatrics, as being our primary care. OBGYN really toes the line, and we've done that on purpose over the years. We like to keep one foot in the specialty realm, and yet wellness, I think, is sort of the notion that if we can promote health in general, if we can get people active, if we can get people eating right, if we can get people getting their screening tests, if we can get people thinking about all of the places that health goes awry before it goes awry, then we can overall create a basic, healthier base from which to work from. And that's sort of the primary care philosophy in general. And in OB, we're not exempt from that. We're shooting to take healthy people and keep them healthy if we can.
The importance of the mammogram.
It is important.
Sure.
And screening tests like pap smears and mammograms, which play a huge role in my world, along with specific screening tests, both obstetrics and general, are big parts of wellness.
You mentioned that OB, of course, is part of your OBGYN terminology, but have you noticed, or is it just my perception that in a lot of cases women are waiting longer to have maybe their first baby, maybe their second baby, whatever the circumstances might be?
It's not your perception alone. It's a national trend. We've seen teen birth rates drop steadily. There seems to be a shifting attitude about teen pregnancy in general, perhaps a wider acceptance and usage of birth control, but it gets back to an attitude. Plus, we live in a society where in order to be in the upper scale of employment, we're valuing education. People are going through college and sometimes grad school, sometimes medical school. They're delaying childbearing until later.
Establish their career.
They're doing all of those things, finding the right relationships and living independently until later. And so we are seeing a lot of people having their first babies much later. On average, I think the rates have gone up about a year across the nation. And I don't have a real clear feel for that trend right here, but in Santa Fe, New Mexico, where I just came from, that's an older population in general. And certainly I had more 40-plus-year-old pregnancies than I had 16 or younger pregnancies, which is just the opposite trend of what we would have seen.
Does that bring more risk?
At both ends of the spectrum do. The risks in advanced maternal age, and that's a term that I don't think any mom ever likes, but we use that generally for over 35. You see the risk for Down syndrome sort of linearly increase throughout the reproductive spectrum from 18 through 48. But the risk hits about 1 in 300 or so at about 35. And in the old days, the risk of doing an amniocentesis to prove whether or not somebody had Down syndrome was about 1 in 300. So the argument therefore was that was the point at which risk sort of equaled out. And nowadays we have a lot better ways of testing and a lot more accurate ways of testing But the risk definitely goes up for things like that. Of course, for general health concerns, there's a high risk for blood pressure, diabetes, and some other things that go into the over 30, over 35, over 40 crowds, and it kind of increases proportionally.
Sure. Okay. Dr. Eric Seward is our guest this morning, OBGYN at Woodlawn Hospital in Rochester. You mentioned women as they get to later years, too, in terms of the menopausal things, and a lot of that has changed medically.
It has, and it continues to evolve. In fact, a big chunk of my practice is dealing with menopause and menopausal issues and the build-up to that, some of the specific problems that go along with that. I would say in any given day, probably about a third of my patients are dealing with either perimenopausal or menopausal issues. Hormone replacement is something that's continuing.
A lot of discussion about that.
Yeah, it's continuing to evolve. And interestingly, at one point in time, hormone replacement was seen as something of a panacea of good.
Sure.
And it does do good. There's plenty of symptomatic relief that can be had with hormone replacement. There's bone strength, skin health, hot flashes, night sweats, the whole 9 yards. Sleep is improved. And on the other hand, we know pretty definitively back in 2002, there was a huge study, the Women's Health Initiative took a really hard look at hormone replacement and found that there was an increased risk for blood clotting, which we knew, but the significance of that clinically was a little bit clarified by that. Risk of strokes, pulmonary embolisms, DVTs, which are all blood clotting related problems, all showed up in that study. And so it muddied the water, shall we say.
Sure.
And a lot of primary care folks just stopped giving hormone replacement. Now, medicine it works on this sort of system of pendulum swings.
Okay.
And a lot of times you'll get everybody goes one way, and then they kind of fall back to the middle, or even the other way, and bits and pieces get clarified over time. And now we're certainly seeing more hormone replacement, but selective hormone replacement. It's kind of difficult. When somebody has an infection, we oftentimes will give an antibiotic.
Right.
An antibiotic, the principle behind giving an antibiotic, or most prescriptions, would be to give the least amount that gets the job done over the fewest possible days. It improves compliance. It avoids some of the risk of creating superbugs and whatnot.
Sure.
Well, hormone replacement doesn't get better in a week. The hot flashes just sometimes go on, and on average, it's a 2-year process, but for some women, it's 10, 15, 20 or more.
Exactly.
And so it's always tricky. In general, the health risk is sort of an individual risk. In a thin person with a good family history, a hearty constitution, who's out exercising,
right,
theoretically has good blood circulation, minimal other risk factors, high blood pressure, etc., diabetes, probably can do well, and probably will have general good outcomes from hormone replacement a little bit later than some people that have other risks. And in general, we're trying to apply that same principle, the least amount for the least amount of time to get the job done within reason.
Will the thinking change over the next 10 years?
Yes. Yeah, probably over the next year. Every time you go to a conference, something new is out. And there was a kind of an interesting, and I'm going to fudge the numbers just a little bit, but there is something like 5,000 new articles every year that just deal with nothing other than obstetrics and gynecology. And there are several major publications, some of them through ACOG, which is the American College of Obstetrics and Gynecology, our sort of mothership, if you will. And that's a lot of information. And some of it is arcane and very specific and very scientific. But within that, that mountain of material, there are going to be things that push the pile a little bit this way or a little bit that way. And it's also regional. Interestingly, out in Santa Fe, where we had a huge retirement population, people came there from from Los Angeles and New York and Florida, you name it, and very active older people who were out hiking in the mountains and skiing and whatnot. We had a lot of 60 and 70-year-olds wanting hormone replacement. My experience in Indiana when I practiced in Marion was it was a much lower interest level, and it seemed to be tailing off in those years. So I think it's a very regional thing as well.
Is that because people in Indiana don't exercise as much as the people in New Mexico do?
You know, I think there's probably some pockets around the state, but I mean, just being the kind of retirement community that Santa Fe is in particular, I don't think that all of New Mexico necessarily fits that model, but that particular community, you're getting some of the most active people from all over the United States kind of landing in a place where it's easy to be active. I think we certainly have some folks, probably people living on the lake, some of the folks over living on maybe like Kentucky or that are fit that exact same model. They may be a slightly more local, Chicago and Indianapolis and whatnot, but we, I think it's sort of it's regional in distribution, but mostly based on the sort of that profile of the active older people.
Dr. Seward, as our conversations continue, what types of topics can our listeners expect to hear about?
Well, I'm hoping to kind of touch base on a lot of different topics. And we're going to kind of piece this together a little based on where the interest lies and a little bit based on what I think needs to get out there. But we've got some general wellness sorts of topics, like, for instance, exercise and diet, screening test, just sort of general things. We'll probably at some point we'll get into mammography a little bit. We can talk a little bit about pap smears as screening tests, maybe some of the other blood work, cholesterol, etc. We can talk a lot about some of the big topics like pelvic pain, which is a big one in my world, some of the tumors and cancers and things that come up. We deal a lot with ovarian, uterine, cervical cancer, some of the benign tumors like fibroids and ovarian cysts, big things in my world. I like to talk a lot about some of the general obstetrics things that we would like to get done or accomplished with our patient populations. I'd like to talk a little bit about ultrasounds. One of the big exciting things that we're working on at the moment is getting 3D ultrasound in the office.
Cool. And
it is cool. It's, in fact, just going through this process of bringing in vendors and looking at different options. Those days are just exciting, fun days for me because it's just amazing what the technology can do.
And it changes all the time, doesn't it?
It does, yeah. We'll probably want to talk at some point about there's a free fetal cell DNA, or cell-free fetal DNA testing, which is blood testing. It's very interesting stuff. Blood testing that you can pick out fetal tissue from maternal blood. You can pick out fetal DNA. They can culture this now without doing amniocentesis and more invasive things. You can literally find out the sex of the baby. You can look for just about any kind of genetic problem that may come up. And it's sort of the new agey way of screening for problems. It's becoming a little bit more common, and we're going to be doing those blood draws in our office, working in conjunction with our maternal fetal medicine specialist up in South Bend, Indianapolis, Fort Wayne, etc. Yeah.
And again, we remind you too, Dr. Eric Seward, if you have a question that you would like for him to address, you can, of course, call him directly. We'll get to that in a second, but you can also post those on our Facebook page or give us a call here at the studio or email wroi@rtcol.com. Dr. Seward, where is your office?
I'm actually in the Woodlawn Hospital. We're part of the Woodlawn physician group there. If you pull into the hospital, it's not a big, complicated place, but there are two carports that you immediately see. The rightmost carport that when you pull right up to the hospital has a concierge parking, and if you go right in that door, right upstairs, we've got an office, we've got pediatrics, we've got family practice, internal medicine, We've got a family practice nurse practitioner that works full-time. We've got general surgery. And then we've got a few people that come and go, urology. And then I'm there kind of in the middle on the left side. It's pretty obvious once you get into the office. I think it's just a really great setup. Of all the places that I've traveled and been, and this may be a testament to a little bit of why I'm here, I've never been in a friendlier place. That hospital is really based on service, and the things that we're trying to accomplish are hopefully done with a smile on faces, and in the pain. This is always a painful process going, even if you're going to the doctor just to get a physical or do something benign.
People still get a little nervous, don't they?
Yeah.
Going to the doctor.
Yeah. So anyway, so our office is there. We're hoping to basically see as many patients as we can. We're getting busy right now.
Good.
Again, I think it's probably about a 50-50 split of obstetrics and gynecology at this point. So far, business is going good.
I guess the one thing I've noticed in our discussion this morning, OBGYN, I used to think was a very narrow spectrum, but obviously from what you're saying, it is not. It is very wide-ranging with a lot of different mechanics in it.
Yeah, it's kind of interesting. Every once in a blue moon, I'll get asked the question of why did I choose obstetrics and gynecology? Of interest, when I was a kid, I mowed the yard of an anesthesiologist. He paid well.
and tipped well.
Yeah, and he told me, and I remember this very clearly. He was like, "Well, I don't care if you go to medical school, I don't care what you do. Just whatever you do, don't go into obstetrics and gynecology." and I just, I filed that away in the back of my mind, and I went through the process. I thought I wanted to be a general surgeon. That was sort of my intent. But I see medicine as sort of filled with sort of three major aspects. One is the specialty care, procedural, surgical sorts of things, which I not only do I like, but find that I have an aptitude for that. But I always loved the relationships too, and primary care is all about the relationship. Sure. So it's getting to know somebody over and over again, and then what we would like to call acute care. So like ER care, you get somebody that comes in with a specific problem you're addressing right there on the fly. OBGYN is kind of an interesting specialty in that we get all three of those. We get that acute care in the obstetrics world, sometimes in the ER, where you get somebody that comes in with a specific problem. They're in labor, or they have a specific issue. You get people that come into the ER with a miscarriage or some other specific problem that we need to address on the fly. I get nothing is more primary care than the obstetrics patient that comes in and sees me maybe 13 or 14 times through a pregnancy, maybe an annual exam, maybe another pregnancy. I don't know a primary care doctor who sees a patient more than sometimes 30 times in 2, 3, 4 years. And you really get to know people, which is interesting. And then we have a pretty giant surgical part of our specialty too. And I spend every Wednesday in the OR. I do a lot of procedural things, and so a lot of and we do some of that in the office, but a lot of it is directly in the operating room, and that's sort of a full spectrum practice. It's got a little bit of all that. I always liked the old guys at the VA and the kids. I really thought hard about pediatrics, loved them, but in the end. Despite that anesthesiologist's best advice, and his advice was purely based on sleep at night, I believe. And I have to. There have been moments.
I'm sure there have been.
There have been moments I thought, why wasn't I an ophthalmologist? But as an OBGYN, it's very satisfying most of the time. You feel like you do good work and help people. And you get a little bit of all that.
Sure
it's exciting, it's technical, and you really get to develop some relationships.
Again, Dr. Eric Seward, our guest, we're going to be visiting with him on the fourth Monday of each month, so get your questions ready. And Dr. Seward, anything else we'd like to add today?
No, I would say that if there are questions, certainly either forward them here, bring them to the office. We really we're trying to build up something top rate. We've got patient care, patient satisfaction, and good outcomes as sort of our top goal.
Excellent.
I think that our hospital in general is working on that as primary goals, but within our little corner of the hospital, we want to make sure that we're kind of elevating the profile of quality of care and quality of service. And I think that so far we're on the right track.
Excellent. Dr. Eric Seward, again, our guest. Dr. Seward, as always, thank you very much. Thanks for your time this morning. Good information.
Thank you.
Look forward to the next visit.
Right.